Sorry. Oh, yeah. Thank you.
Can patients have access to their documented notes from the MDT meetings?
Yes, I think that basically notes are always available to patients to have a look. I think in most centres the MDT discussion is either produced in the form of a letter which goes into the patient's notes, or some of us use computerised notes these days, and it's all part of the set of notes. So if you wanted access to your notes, it would usually be as part of that. So certainly, I'm sure you could access them if you wanted to. But what I would hope would happen is that your treating doctor would also make sure they fed back the MDT discussion to you and hopefully talk to you about it.
Yeah.
But you should be able to access your notes and MDT discussions without any problem.
Just ask your oncologist and hopefully.
Yeah, they should be able to provide that for you. Yeah.
It's not today what you could spoken about.
Well, I know exactly because as it's it does exactly, that's right. It can feel a little bit strained, but I think it's mainly looking at your test results and coming to what is a good treatment plan. But that's got to be taken back to you because you might not want that, and that's the crux of it, isn't it?
Julie.
How would you feel if the patient asked to be present at the MDT discussion?
Okay. I wouldn't have a problem with it in theoretically, to be honest, but I think one of the problems is that a lot of these meetings are really, really very busy in terms of 20 patients being discussed, and so it could potentially be difficult for that reason. But there are some MDTs where what they do is they would have a discussion. It's more like a clinic, a bit really like the portraitist clinic, where maybe the clinicians would meet for an hour beforehand and then see those patients straight after, which is a bit like that really, and so that's the way forward. I think a lot of them in sort of busy practice, in sort of things like in the more common cancers, just the logistics of that potentially would make it more difficult. Okay. So should I say boo?
I'll shout.
Okay, sure.
It just struck me that when you were going through the list of people who generally participate in MDT, that there doesn't seem to be any social care practitioner.
Okay.
And I can see that in cases which perhaps are either simple or where people are fit in well in other ways, that might not be a problem. But where there are more complex needs, I wonder how that side of things is fed in.
Okay. That's a very relevant idea, actually. I think probably in some MDTs, in particular cancer types, there may be. I think what probably happens in the more common cancer types is that the MDTs can become more of a business meeting, making treatment decisions quite quickly about quite a number of patients. And the idea then is that is then fed back to the patient, obviously in the clinic, where they should then have access to other areas of expertise such as social care and all those sorts of things. So it's not that that's ignored, but I think that again, sometimes in a very busy meeting it can be more difficult to go into those sorts of details.
I'm just thinking though that there are all sorts of factors which should be identified through a community care assessment or whatever, which could impact very closely on the kind of treatment
absolutely.
plan.
Yeah, and I think that one of the roles of a sort of key worker or a specialist nurse is to make sure that some of those factors, are, the really important ones, are flagged up early, ideally at the MDT meeting. But sometimes, even in that situation, it changes when you actually come back and talk again to the patient about the options, and you may come to realise that something which should be mentioned in passing is actually much more important than you originally thought. So things do change from what's decided in the meeting to then what actually happens. So it is a bit of a fluid process. But I do think that having a social worker or someone of that type would be very helpful in some situations, absolutely. Any other questions at all?
Did you have a question?
Do you, or
Have you ever encountered a situation where you discuss the patient and then you come to the options, but some of the options may not be available at that particular hospital?
Yeah.
Do you ever get the situation where someone says, well, this patient is ideal for this sort of option, we should recommend that they go somewhere else?
Yes, no, that absolutely happens. So where I work, there are a few treatments that you know, are particularly specialised for esophageal cancer, which we don't provide in South Wales at the moment. And so very occasionally we come to the decision that that type of treatment is what is required of the patient, or is certainly the best treatment available in the UK. And so we would refer that patient on to, you know, a specialist centre. So that does happen quite often, you know, across the country, particularly in, you know, in these sort of rare tumour types. So I think that's not unusual, and I think that there are less barriers to that now than maybe there were a few years ago. So I think that most people feel pretty happy referring on, basically, you know, for specialist care in that situation.
What about financial considerations? How much does that impinge on I think in most MDT we're not thinking about cost as such. There are bodies such as NICE that look at drug costs and costs of different treatments. And we are sort of guided by them, or we have to work within that framework. So, as this gentleman said, you know, if you're going to be treated in another hospital, you are aware there are financial costs in
absolutely. Yeah, I mean, that's true. I think, you know, if we have to refer to a centre in England, then it's a different system in Wales than it is in England. And so there's a certain process we would need to go through to make sure that patient is funded to go elsewhere. But it's not a complete barrier, and we do quite frequently do that. So there are financial constraints, but I don't think it's something which generally at an MDT level we routinely worry about on a week-to-week basis. Now and again, you know, if we want to refer someone for a high-cost treatment, then there are, you know, sometimes sort of hoops we have to jump through, if you like. But I think the NHS these days allows us to do that.
Whose job would it be to negotiate whether the person could have a certain
treatment?
Pardon?
It depends on where you live. So usually if you have an oncologist that looks after you, it would be their job to try and access exceptional funding, or you know, for a treatment which is not considered standard, basically. So usually your treating consultant, whether that be an oncologist or a surgeon, will do that for you.